also happens to be active plus the NPH, so it is also given half an hour before the meal. Insulin are now not used so commonly. We can skip this out to round 9. And just a second. No, Vishnu, insulator are you selling insulator?
I'm just selling, sir,
but it's almost getting out of it. So we can remove this part. We come to this activated and restart. So half an hour before food, you give an injection, have the food. The peak action you reach is around 3 hours after the insulin shot. That's technically 2.5 hours after food, right? 2.5 hours or 3 hours after food, which is actually the peak time of your blood glucose physiologically. If you're a diabetic, because that is all slow, because the second phase of insulin release has been slow. And in the normal individual, the first phase of insulin release after food, after glucose load is within 5 minutes. By 2 minutes it starts hitting up, 5 minutes, 10 minutes peak, it comes down, then a small break. And that happens because there are very readily available insulin pools in the cytoskeleton of the membrane. And when there's an exocytosis, when there's a glucose on the cell understands that there's a glut receptor which brings up the glucose into the skeletal muscle. That's one mechanism how the insulin sensitization happens. And what happens in the pancreatic beta cell is that the potassium channel closes, the calcium channel opens. The calcium immediately comes inside. What is calcium? Calcium is a squeezer. We all knew this from. And also in the beta cell, you have very smooth actin filaments, which squeeze insulin, which is there as readily available pool, and also an immediate pool, readily immediate. So immediate ones immediately come out, and that causes the first phase of insulin secretion. But that is slow. That is almost 5% of the pool in the beta cell. So that comes out and that wanes off basically within 10 minutes. The second phase, which is there stored, and that comes again down, one after the other. They are laid down on this membrane and they come out of the membrane very slowly. And that takes almost 2 hours. But the peak is usually around 90 minutes to 2 hours, 1.5 hours to 2 hours. So the new Monier paper says that you can actually, if you're a normal individual, to prove that you are the highest sugar level can be measured at 90 minutes post glucose challenge. But in a diabetic, this slow phase also is so slow that perhaps it hits around 3 hours after food. So there, these mechanisms work well, right? So, and they will last for this whole duration for active lasts for 8 hours. That means it has a prolonged action, and which is not the physiological action, because physiological action comes down by 3 hours. So this is not the physiological of molecules, right? So the limitations are it is slowly absorbed, longer duration of action, lower quality of life because you have a lot of hypos and the adjustment problems because it overlaps with the lunch, etc. And more variability, unpredictable glucose values. And variability we know is a dangerous thing because there is a concept called mean amplitude of glycemic excursion, that 446 and 40, which is worse. So the shortcomings of human insulin, we'll see the physiological insulin profile. The basal component is this, meal-related peak. Then you have if you give a premixed human insulin, it fails to attain that amount, it brings down that amount of glucose. So this is actually the normal insulin level, which is higher than the premix that we normally get, like a human mixed start, 30-70 we get. So this insulin level is also not that high to combat that glucose, number one. Plus the action is very prolonged. Okay, so it doesn't match this orange one. The gray one doesn't match the orange one. Now, this is the period of unwanted hyperglycemia, naturally. So this is that 446 period perhaps. And then this is the period of unwanted hypoglycemia when at 5 o'clock that man who is taken refuge has 40 sugar. So this is the Scilla and the Charybdis problem. Now, to have the good balance, we need to decrease the increased risk of complications from hyperglycemia and also decrease the risk of hypoglycemia. So, therefore, the insulins are changing now with recombinant DNA technology, you have the newer analogs, and these are called modern insulins. They differ by one or few amino acids from the primary structure of insulin. They developed to provide more physiologic replacement after subcutaneous injection of human insulin. They're made possible by the advance of biotechnology or the recombinant DNA technology, and they provide more optimal benefits. The insulin analogs, they are addressing the limitations. What are we actually addressing? We want something that will mimic the physiologic insulin secretion, which in the last 3 slides back we saw that it is not happening. Better time action profile than human insulins, have more predictable action, superior postprandial reduction, more cardiovascular benefits. Dr. Jha just finished his talk, and I'm sure that you could make out, and he has also very clearly elucidated on this point, that PPBG, postprandial blood glucose, is also a major determinant of cardiovascular risk and the events. Because it has been also shown that the myocardial perfusion in a patient who has ischemic, underlying ischemic element also comes down abruptly with high postprandial glucose. It's like a tsunami effect. And that's the reason the IDF recommendations guidelines, when they talk about PPBG, they show this wonderful tsunami, that curve, the wave that they have to bring it down. More safety, less hypoglycemia, less undesired weight gain. Mealtime flexibility can be taken just before or after food also. And convenient to use, available and simple to use pens with painless needles. Now these are the flex pens, and suddenly because of these pens, UK 2 years back, UK actually has stopped selling human mixture. UK only sells Novomix because it's a government sponsored, so they don't buy from their pockets, and it's such an easy pen that they hate to see the old pens that we still use. Insulin analogs, the classification now is rapid acting, aspart is for the lysine, long acting, detamir and glargine, and the premix is biphasic insulin aspart or lispro mix. So these are the available analogs that we have. In premix, this is the change. You had aspart, this is the insulin aspart, you had a proline in the P28 sequence, the proline is gone and aspartame has come in. So it has become insulin aspart. Now the formulation is, this mix is actually a soluble insulin aspart, where 20% is the rapid acting, and the 70% is protamine crystallized. This is crystallized insulin aspart. So therefore, a good solution. Whereas this is the soluble human insulin, which is 30%, and this is the NPH, which is actually in a suspension. So you see suspension. So when you mix them, you get that cloudy mix, and here that comes as a single insulin because it gets. This is aspart in the solution. This is something to understand. And the dual release mechanism is, you have this normal physiological insulin. Then if you have insulin aspart, which is close to like this physiological peak, and the longer acting insulin analog for basal needs goes like this. Now, if you have a substantial breakfast, for example, all the people who work or who go out to work are advised to have a good kind of a meal in the morning. During the day, perhaps if not such a sumptuous big meal, so it is covered somewhere here, and then you go back home and you have another meal. So premix perhaps will be the order of the day for anybody who goes out to work like a common man. But if you are at home and you are in a convalescent state, or you are in other very elderly, then the mechanism is different. Then you have to regularly monitor, give 3 shots of rapid ones and 1 basal, and that's different. But for a normal individual who goes out to work at has the main meal around 9 o'clock, and then has kind of snacks or tiffin during the day, small, and then come back home around 7 o'clock and has a good meal again at 9 o'clock. Then for him, the mixed preparation, and that too, this kind of a physiologically good mimicking mix would be better. So premix analog for both meal-related and basal insulin. Premix analog closer to physiological insulin secretion, because this is also the physiological basal which is continually happening in an individual. This is the timeline of how it started the development in '91, and then it was finally launched in the European Congress in 2000, and there we have it in September 2003. It was launched here. So pharmacokinetics, you see a lovely physiologically mimicking one. The mealtime flexibility, you see, after preprandial injection, this is the plasma glucose, and this is after preprandial, this is after postprandial injections. This is a wealth of data that you have from the randomized clinical trials from Initiate, Euromix, Action, and these are present, improve, and A1 achieve, A1 achieve. And this is how they show that the A1C reduction is in Initiate, it was from 9.7 to 6.9. In Euromix, it was from 9.2 to 7.5. In Action, it was 8.1 point. So it was always remarkable. Right? For fasting blood glucose, again, from 14 to 7, highest excursion. Till this. For BP blood sugar, this. We are still, are we still with that extended trial period that we had been enrolled? That improved thing has stopped. Right? So we are this close where we were, we were investigators. Consistently low risk of major hypoglycemia. You see the major rate of events almost not there. And this was major events per patient year. And the A1C decrement. A decade of data in different patient population showed that A1C improvement in insulin in 9 patients who had never given insulin before. Coming patients who came from biphasic human insulin, that's the human mixed start 30, and the patient who came from glargine or determin. Improved fasting and PP for also the same category. They were very highly approved and recommended, and reduced major hypoglycemia also in these 3 categories were better. Now these were the superior and safer therapy trials, which I will just briefly touch upon. See, the premix human insulin showed blood glucose was higher. In the aspart group, it is definitely lower. It is lower by 1 millimole per liter. That's 18 or 20 milligrams per deciliter. Same dose. Superior BP blood sugar control vis-a-vis. So, see the preprandial glucose increment in Ovis was less. It was more, 30% less. Low risk of major hypoglycemia, 50% relative risk reduction from Ovis. Reduced major hypoglycemia compared with insulin. Then you talked about, this is Vegelic's paper, where before therapy and after therapy, talked about fasting, PP, A1C hypoglycemia, Novomix scored better. Comparable HbA1c reductions achieved with lower insulin doses. See, this was the UK patients with type 2 diabetes had very lower insulin dose. So what was the insulin dose? If for that adequate achievement of A1C comparable, you had both of them had 9% to start with, and both of them achieved 7%. For that, if you were giving them, you will mix up 30. 67 was perhaps the dose of total DDD, total daily dose. Here, when you gave that to achieve the same HbA1c, it was 40, so almost 20% dose reduction, which again contributes to less amount of weight gain and a better feeling. And increase required to achieve the insulin dose. See, in how much increase that you did to require to achieve that goal. You started with X, and then you increased to 75% of that from that dose. You achieved that 7% reduction. But when you started with Novomix, you perhaps increased to only 15% to achieve that dose. Patient's treatment satisfaction, efficacy, relief of symptoms, relief of burden, all mean change of score and the 26 weeks timeline, they all had better results for Novomix. This is the clinical effectiveness of biphasic insulin aspart versus the human mixture. in the UK general practice, which showed that the mean change of A1C was very, very significant. The rate of hypoglycemia, the same kind of studies. But there are two slides which I'll now show, saying that this is the Novo mix, which went on to measure, because routinely we measure the cardio ankle vascular index, which is the we do a Doppler for everybody. So the ankle vagal index is a marker of arteriosclerosis, and this high, it is more than 0.9, then it reflects the progression of atherosclerosis, whether it's cerebral, coronary, whatever. Now, this patients, 26 patients who received the human mixed-up 30 enrolled. The human mixed-up 30 treatment was continued for 3 months. All the patients switched to Novomix 30, and then it was calculated before and after Novomix. See, there was a significant change, and that went on to prove that it is doing better. But unfortunately, you don't write Novomix, for the reduction of the risk of CVD. This 1-2-3 study is a similar kind of a study which is given to patients in a phase 1. Was start with an OD dose pre-dinner, that follow it up for 4 months, 12 units dose. See if the A1C comes within 6.5 or insulin 9 patients. Then forget it. If it doesn't come, then go to BID, right? And then you add breakfast, pre-breakfast and dinner, right? Add 3 units at breakfast and then titrate also the dose. If it comes below 6.5, good. But if it doesn't, then you add TID. So you add also lunch, start with 3, and then again up titrate and get H1C below 6.5. Now what they showed, these are the baseline treatments, this was the disposition. The AAC and the IDF goal, which is A1C of 6.5, and the ADA goal, which is less than 7, it was achieved in 6.5 was achieved in 21% of 1-2-3 study and 41% of OD dose. So only one bedtime dose, you achieve ADA goal of 41%. You give it twice, then you get 70% of the ADA goal. AAC and IDF is a little more stringent, so you get more than 50. And then TID dose, you get more than 75% of that, and around 60% you achieve AP1C of 7 or 6.5, who started with a baseline of 8.6. Now, why I'm talking about this study is not to reiterate all the points of less hypoglycemia or better control, but to share with you this view, that it also showed, and it was published in DPTOM in 2006, that the pleiotropic part, the arterial stiffness part we shared, and this is another part. Talk about systolic blood pressure, talk about diastolic blood pressure, talk about the triglyceride, the total cholesterol, the HDL raising part, everything was good, with Novomix. Okay, the BMI and the weight gain was there, naturally, like any other insulin. So the average dose, etc. Now, talking about the safety meta-analysis of hypoglycemia, this study, which was Davidson study, shared almost equal 50% of Asians and around 50% of Caucasians. So many subjects, they showed 57% were male baseline demographics. They showed an overall, this is the odds ratio 1, and on this side it's favoring Novomix, and on this side we favor human mixture. So overall it showed 0.45 was the odds ratio towards this. So it favored Novomix in terms of less hypoglycemia. In terms of nocturnal hypoglycemia, was significant, again 0.5. This is again another postprandial glucose study in the Indian perspective, the A1 Chief study. So many patients, this was global, this was Indian, total, no therapy. This was pre-study. This was oral plus insulin, right? Indian patients showed higher PPG level at baseline. Right? Incremental areas under the curve between Asians and Europeans. This was the incremental blood glucose curve. This was much more here in the Asian. So then, what they concluded was that fasting, and we know that fasting hyperglycemia control is of course necessary, but that doesn't contribute to from that seminal ammonia paper, saying that more than 70% of PP, because an average Bengali or an Indian spends almost the 24 hours in the PP state. he hardly has in a fasting state. Because when you have dinner so late, and then it takes, it is not easy to digest that bit of carbohydrate, and by 4 o'clock, 5 o'clock, if you are away, or if you go for the first flu, you open the fridge, munch something, or you are offered tea if you have an elderly ma or baba at home, so you're always in a postprandial state. With view of that, if you see that in individuals with A1C of less than 6.5, post-load dysglycemia that predominates. And if you talk about the type 2 diabetes, if you talk about pre-diabetes, everywhere you see this is the this is 140 to 199, and this is above 200. So whether you are in a 4.3 A1C state, still there is a huge load of this amount of abnormal, which we hardly check our PP 75 gram glucose. If we all check, perhaps in this August gathering, everyone perhaps would come up with a figure of 141 or more. And so all of us will perhaps, if we have an A1C of say 5.3, by ADA definition, you are nowhere, you are normal. If you cross only 5.7, then you are pre-diabetic. Even if at 5.3, perhaps you're in a pre-diabetic state, your PPBG might be 141 or 142. And this will sadly and slowly, finally, bring about that geopathy, which you hate to see one day. So finally, it's a contribution of, we know that it was seen on continuous glucose monitoring, and that it showed that excessive postprandial hyperglycemia was such. So the relative contribution between 24-hour hyperglycemia and 4-hour hyperglycemia after meals were also shown to contribute how much to A1C. But that brings us to this point that PP blood sugar has to be kept in mind very strongly, especially in Asians, in our population. And so therefore, a control of that magnitude to that physiological strength is very, very important. And how do you do it? First thing you do is, if you start once daily dose, say 12 minutes. You can do it in the morning if the pre-dinner dose is high. So if you come back from office, you have had so much of food from the office, also so much of food for thought from when you're back from the office, that your blood sugar is up. So you start with a 10 units of insulin in the morning. And in the evening, and you can start also an evening dose if the pre-breakfast blood glucose is high. When you wake up in the morning and see your fasting is 140, you can start those in the evening when you come back home before dinner. Then split the dose when the dose is 37, when the dose is above 30. When you're either pre-dinner or pre-breakfast is going above 30, you can break the dose. Now usually they say that you can break the dose in almost half, but ideally because we keep on munching something between the breakfast and the evening dinner, it's not the evening snack like in the West. It's preferable to have a 2/3, 1/3 predisposition of dose delivery, or if you really have what is called an offered lunch in a lot of these offices, then you will have to have one small dose of preprandial or a mix before lunch. So that's how it has been explained here. Initial dosing, how you do it. So these are all kind of this is an algorithm. This is laid down by the IDF, and Jackie has also kind of copied this. But I don't particularly believe saying all this. I believe that the patient needs to be understood well by the physician and well by himself, and he has to regularly monitor and understand the curve span of how his sugar is behaving throughout the day. With Murian Bhejashkola, it is say 170, and Murian Wanmuto Gatia, it is 240. So he will not have Gatia anymore. He will not have, and so Chola is preferable. So what are the things? And how do you do it? There are a lot of mechanisms. You do it by 7-point finger testing. You do it by continuous glucose monitoring. But the patient has to be apprised of what state of blood sugar he is in throughout the span of the day. What are the meals that is causing the problem or are good for him? And he should try to appreciate that. Our task is to make him appreciate that, and then empower him with the knowledge of what should be given at what point in time. So these are the important issues, like why you need to have analogs for predictable action, superior BP control, which contributes heavily to all the risks in India, better glycemic, less hypoglycemia, less undesired weight gain, mealtime flexibility, available, easy to use pen. Thank you.